So Dr. Edwards, thank you so much for having this opportunity for me to ask a couple of questions. Yeah. I primarily got a question when it kind of pertains to different approaches in tumor removal. Mm-hmm. One of the biggest questions I have right now is, could you describe the anatomical structures a surgeon needs to navigate when performing a alveolar approach or I totally forgot the name of it. But
telovelar
approach.
In the posterior fossa.
Exactly.
Okay, so just generally speaking, we like to think about intricate anatomy, mm-hmm. and in some respects in surgery, we're not thinking quite as intricately, if I'm honest, as what you would think in a textbook. Mm-hmm. You want to make sure that you understand your superficial structures and the next layer. So we're thinking in layers, right? Mm-hmm. Skin, muscle, bone, and then when you're looking to access the intracranial space, you have to go through the dura. So you have your sinuses, which are filled with blood, venous blood, superior sagittal sinus, transverse sinus, sigmoid sinus. Those are really important structures because if you get even a tiny hole in the sagittal sinus, for example, it'll bleed a lot, really fast. And so you don't want to experience that at all. And then in the case that you're talking about with the cerebellum, you can resect the cerebellar tonsils. They're not critical structures in function. And like for a Chiari decompression, for example, we will frequently resect or coagulate and shrink back the cerebellar tonsils. You can split or separate them one from another, and that gives you access to the fourth ventricle. If you have to get further up in the fourth ventricle, you can split the vermis, but that can cause some problems. And it's commonly done in pediatric tumors of the fourth ventricle where they're big tumors and you have to get all the way to the top of them. But the kids can have some difficulty speaking after. And so another option is to sort of navigate around the vermis and expand your approach to the fourth ventricle by expanding that arachnoid plane, which is what you're mentioning. Mm-hmm. And so that's really just expanding the subarachnoid plane and separating further the structures, which is another principle of cranial surgery in general. If you can separate arachnoid planes from each other, you can move things apart safely to give you better access. So for example, if we're going in to do a tumor like a craniopharyngioma from a pterional approach, we would be removing as much bone as we can so that the bone's not in our way. And then we would be splitting the sylvian fissure so that the frontal lobe and temporal lobes can fall further away from each other. We don't have to transgress any brain tissue to get to the optic nerves or the anterior and middle cerebral arteries, or in this case, for example, if you're doing a craniopharyngioma, you could be looking right at the tumor. And the telovelar approach is the same principle. It's just widening those arachnoid planes.
Okay. And in similar approaches, when you need to get into some deep intrinsic locations within the brain, how do you plan the preoperative approach in determining what the best method would be to address those tumors?
Yeah, so the deeper you get in, you just have to pick what's the safest, what's going to give you the right corridor and angle. Sometimes you do have to go through the brain. For example, tumors inside of the ventricle, a colloid cyst, or maybe 3 months ago, we did a very large meningioma that was inside of the ventricle. Like the only way to get to it is you have to go through the brain. Mm-hmm. And so in that case, I looked at the anatomy and said, well, I'm going to go through the brain in front of the motor strip, get down to the tumor, and then stay within the tumor. And I went obviously in front of the motor strip because going through the motor strip would be a problem. Mm-hmm. You can get creative. For example, a pituitary tumor, it's right in the center of the brain, but you can actually go through the nose to get there, so you don't have to go through brain to get to the pituitary gland. And then you have expanded endonasal endoscopic approaches to reach a lot of things through the nose where you don't have as much brain tissue in the way. But it's a question that entire books are written about, and lots of different ideas on ways to get to certain places. It gets super intricate when you get into brainstem cavernomas, and that's probably beyond my pay grade as a general neurosurgeon. But there's certain centers around the country, Barrow Neurological Institute, for example, that's developed very intricate corridors to reach cavernomas safely, which is a high real estate area, deep, lots of tissues and important structures to keep in mind. So it's something that you can spend an entire career studying and still not have a perfect answer to every perfect approach.
Yeah. And you mentioned different angles. How do you plan positioning the patients when determining what the proper approach or angle would be for any given number of tumor removals?
So patient positioning is one of the most important things in surgery. If you don't get the positioning right, your surgery is going to be way harder. Mm-hmm. We want to be working in angles that are comfortable for the surgeon. If I'm operating with my arms way up in the air and at an awkward angle, and I have to be like that for an hour or even 10 minutes, all of a sudden you're in pain and you can't think, and it's awkward. Let's take, for example, the telovelar approach you mentioned. And it's similar in some respects to just doing a Chiari decompression. So with a Chiari decompression, our angle is going to be from inferior to superior. And so we want to flex the neck forward and pull the shoulders back, and then get the head almost lower than the shoulders, because that way we have a much easier angle to the posterior fossa. Now, if we were doing a surgery on the cervical spine, we would have more of a capital flexion approach, where there would be it would be like a military. This as straight as possible, the chin is tucked back and the head is extended this way, versus for a Chiari or getting into the fourth ventricle, we're going to flex them way forward and almost tuck the chin down. And so similar areas, but the angle and positioning is completely different.
Okay. For imaging prior to the operation, when a lesion is suspected, what are the different types of imagings that you would typically order?
That's a great question. So CT scans can give you a lot of information about blood, about bone, and is a quick study. MRI gives a lot of anatomic detail with the brain and its surrounding structures, the nerves, the CSF spaces. We can get contrasted imaging. And then you can start getting into diffusion tensor imaging to look at the white matter cortical or the white matter tracts. That gets quite intricate and is a wave of improvement in cranial surgery, where you're understanding the white matter tracts, not just where the gray matter, Broca's area or the motor strip or the sensory areas are, but the deeper white matter tracts and how to work around those. The other really helpful imaging modality is stealth. So using an MRI scan, or it could be a CT scan, and they get extra slices and then register that image to the patient in surgery, allows us to plan a trajectory to the lesion, making our incision and even knowing where we are in space during surgery by checking the stealth navigation has been a great advancement in the safety and efficacy of cranial surgery.
Wonderful. One final question I have is, two final questions, is when it comes to determining if it's a primary or secondary tumor, is that done only post-operative or during the operation when a biopsy is
A
done?
lot of the brain tumors are pretty easy to tell on imaging. Meningioma is fairly straightforward. It could be something else, but it's like, well, that looks like a meningioma. A glioma is like, well, that looks like a glioma. Glioblastoma, it's like, again, that looks like a glioblastoma. That looks like a pituitary adenoma. And the list goes on. The definitive determination for what type of tumor it is with pathology. And we can have a pretty good idea. This patient has a history of a particular type of cancer, and the lesion in the brain looks like a metastasis. It's round, it's at the great white junction, and it is surrounded by a lot of edema, and it enhances with contrast, most likely metastasis. And so we're planning our approach and our rationale for surgery around what we think the tumor likely is, and then confirming it on pathology.
Perfect. And then finally, when in your practice, are there any situations or surgeries that you can think of that knowing the anatomy really proved to be beneficial in
every
helping
surgery?
you?
Every single surgery, the anatomy becomes your guide to a safe approach, to the most efficient way of getting to the pathology, of knowing what are the important structures to protect, what are the important structures to dissect cleanly. And if I were to sort of share with you what Dr. Shaw, who was one of our attendings in Indiana, he's now the chairman, neurosurgery is fundamentally two important principles. One is hemostasis. So you need to know where all the blood vessels are and how to stop any bleeding and avoid significant bleeding. And the other one is tissue planes. Being in the right plane makes all the difference. Staying in that subarachnoid plane and staying in an epidural plane, and the list goes on. So if you can be in the right tissue plane and maintain hemostasis, your likelihood of success in neurosurgery is much higher. And that really boils down to an understanding of anatomy.